Good morning, everyone. Welcome to the WEDI National Conference, a virtual learning experience. Today, we have pre-conference sessions. It's my pleasure to introduce our first pre-conference session that's presented by Axway. Our speaker today is Ravi Shinta, and Ravi will be presenting in just a few minutes. There's a couple things that I wanted to remind everyone, and that is he's very much interested in questions from the audience. Please put those questions in the chat function, and then we will, at the time that he concludes his presentation, then we will direct those questions to him for answering. We are excited for the following days of presentation. That is October 15th. We have one session starting at noon to 1 o'clock, presented by eSolutions, and then we have attachments demo day starting at 1:30. That's presented by Edifax and TIPCO. On the 16th, which is Friday, we have from 11 to 3:30 our WEDI National Conference Attachments Workshop. So again, to sort of do some pre-planning of your schedule, make sure you mark this down, and certainly the overall schedule is online. As I mentioned, please hold your questions, send them to us through the chat function, the chat feature on the bottom of your screen. As a reminder, slide presentations will be available at WEDIU.org at the end of the week. So with that, I'm going to turn it over to our speaker, Ravi.
Thank you, Michael. Good morning and good afternoon, guys. As Michael kind of introduced me just a few minutes ago, my name is Ravi Shinta. I'm the Principal Solutions Architect here at Axway. I have been working with many healthcare payers and providers in the past 7 years, mainly with enabling their API security and API management. Today, I would like to take the opportunity to walk you guys through in at very high level and also in a very generic fashion. And what I mean by generic fashion is, even though I represent Axway, the best practices, the key points that I'll be making are not just confined to any specific vendor solution or software solution. The points I will be highlighting are very generic, irrespective of what vendor or vendor solutions that you're using. Okay, so with that said, Michael, can I go ahead and share my screen?
Please do.
Right, thank you. Sorry, just. Okay, awesome. So today's session, the agenda for today's session is very simple. What I would like to do is set the stage, especially as the title of this meeting says, Open APIs with Trust. If we take that and try to apply to one of the most prominent projects that I'm working with various payers and providers now, which as most of you can already guess, it's about the Cures Act interoperability. You know, how do we enable exchange data between payer to payer or payer to provider or provider to provider using FHIR APIs? So today's session will be laser focused on what are some of the key reasons why Center for Medicaid and Medicare Services, CMS, and the other bodies like ONC, why did they recommended these two protocols here, OAuth 2.0 and OpenID Connect? What was the intention behind it? So we'll talk a little bit about that, and then I will, at very high level, talk to you guys about how these two protocols work hand in hand together, and where they make sense, especially as you start exposing your FHIR APIs to your clients. Okay, so it will be a very high level overview because OAuth and OpenID Connect are the depth and width of these two frameworks or protocols it's quite they're quite deep, and they can go quite deep and quite wide. And I'm afraid I can't really talk to every aspect of these frameworks in this 1 hour call. So I'll be talking about them at high level. As I talk through them, I will pause at certain areas to pinpoint on things you need to consider as we go along. And we'll, once we cover the functional understanding of these two protocols, we'll talk about the risk associated. Just because you secure your APIs using these two protocols or frameworks, OAuth 2.0 and OpenID Connect, doesn't mean your APIs are not vulnerable. There are challenges that you need to be very, very, very aware of, that you need to think about ahead, and you need to have all the countermeasures in place. And beyond just the technology, what are the other considerations that you need to bring to the table as you start exposing these FHIR APIs to your clients? So again, a very simple agenda, but it will be very laser focused on OAuth 2 and OpenID Connect, but also some best practices. And these best practices, again, as I was mentioning earlier, it's not confined to any specific solution or a vendor software. These considerations can be applied to the end solution of your choice. Okay. So with that said, let's set the stage, right? Uh, some of you, or probably most of you on this call, might already know the Cures Act interoperability mandate that every payer and most of the payers and providers are required to meet by July 1st, 2021. And what the Cures Act mandate is all about is, how do we safely expose or share the member or patient related data using FHIR standard, the HL7 FHIR standard, through APIs in real time through REST APIs, right? The link here actually talks quite a bit and in detail about what are the various ways that your customer, a FHIR application would can invoke your REST APIs and consume them. So it really talks about quite a bit about OAuth 2 and OpenID. Where do they? What is the key role they play in the scenario? And what are the various steps involved. So it's a very cryptic flow, but I will try to decrypt it for you all. I'll try to keep it simple, and so hopefully it will be helpful to you guys. Okay, so all right, let's start it. So smart on FHIR application, what is this framework about? Like, why did CMS and the other entities really go about choosing OAuth and OpenID Connect as the standard recommendation to secure your FHIR APIs? There are so many other options. There is two-way SSL. There is some very advanced cryptographic ways to secure your APIs. I mean, out of all the options, why exactly OAuth 2.0 and OpenID Connect? What was the intention behind that? The intention behind is, first of all, OAuth 2.0 and OpenID Connect, these two protocols are very widely adapted in the industry. Some of you might already be using them. Maybe you just might not know. A simple example is if you go to some of these social websites out there, and when you try to register, at the very bottom of those login or registration screen, you see the options, right? That basically says, Would you like to log in? Would you like to register with your Facebook ID, or would you like to do it with your Gmail account, or would you actually like to do it with your Apple account, right? The social logins. And if some of you have already gone through that experience of, yeah, I don't want to really fill all my login and registration information. I'm just going to use my Gmail ID to sign in into this service and start leveraging that service. Behind the scenes, when you are using your social logins in those scenarios, you're already using Oauth and Openid Connect to a certain extent. We just, as an end user of those applications, we just don't know what's goes on behind the scenes. But the key point here is the Openid Connect and Oauth are very widely used protocols, not just for social logins and social frameworks, even for enterprise applications. But one thing, they have been widely popular, and I had the privilege to work with many customers, and it's kind of surprising. Even today, there are customers who are quite confused between OAuth and Openid Connect. Some customers have a confusion of, oh, Openid Connect is same as OAuth, or OAuth 2.0 is maybe it's just a different name for Openid Connect. And that confusion is still real, surprisingly. But for everybody's benefit, let me make this point very clear. Openid Connect and OAuth 2.0 are entirely different. The purpose, their purpose is completely different, as you can see on this slide. Openid Connect is all about authentication, and we'll talk more about what I mean by authentication and how does it fit into this smart app launch framework, especially in the context of FAIR API interoperability. And OAuth 2.0 is all about authorization. Just this is a very key point, and we have to be on the same page on this. Very, very, very important. They are not one and the same. They do work, and they can work. They will work hand in hand, but they are not one and the same. Okay. Now, when it comes to, say, for example, if I put myself into a shoes of a payer, right? Let's look at how these two protocols come into play. Before we look at all the various steps, it's very important to look at what are the key actors, right? When we think about this interoperability rule and exposing your FAIR APIs for consumption in a secured way, what are the key actors who are all involved in this end-to-end play? These terms right here are very technical. Resource owner, client, and protected resource and authorization server. They don't tell you much about how exactly they map. So let's take a look. A resource owner can be a member, right? Who already has an account with a health insurance plan or payer, or it can be a patient who's a patient accessing the patient portal provided by a hospital or providers, right? And then clients, third party. Here the client actually refers to third party FAIR client. It's very critical to understand. If you are a payer or provider, and if you have your own application, obviously you can get access to the member data, patient data in any shape or form that you want. But when you think about third-party client, a client which is not owned by you, not managed by you, not administered by you, it belongs to a completely third party. It can be a different payer or a different provider here, right? Um, and then when we think about the authorization server here, now this is where it gets a little technical in a sense that your member, say for example, would like to use this third-party application or client application, and because they provide this amazing features. A simple example would be this application helps a member to keep a track of how well they are doing with their chronic illness kind of thing, because with this application could be accessing that member's medication information and also allergy intolerance information or certain observation reports, right? So this third-party application might need access to that member's information that is owned by the payer or provider. And then once they get that information through the FHIR APIs, they will take the data. Maybe they are providing this very amazing visual charts to, or showing a nice graph to say that, yeah, you're actually doing a great job based on the observations and based on all the stuff you're doing. You're definitely getting better, right? But in this scenario, the key thing to remember is the member or the patient whose information is owned by the protected resource, which is the member, the payer or the provider. This resource owner, the patient or member, should never, ever, ever, when they are using the third-party client application, they should never share their credentials with the third-party application. And I'll talk more about it, why. And it kind of speaks for itself why OAuth and Openid are so widely popular, okay? And so once again, the key actors are your patient member who can access a third-party application and authorize that application to access their data from within that application. And when it comes to invoking those APIs and accessing the member's information, these clients have to, not only just the member, but the client applications have to authenticate themselves as a legible, verified, and validated client. So this authorization server here can issue what we call OAuth access token, OAuth token to call the APIs. Again, just keep in mind the key 4 actors. The next few slides will clearly outline what is the flow that the interoperability is expecting us to do. Okay, the mandate is expecting us to do. So it all begins with, say for example, I'm going to put myself into the shoes of a member. Ravi is a member, and Ravi now would like to register himself with this third-party client application. And say, for example, from within this client application would like to access my member demographics information, and they also would like to access my medication information and also the allergy intolerance information. Okay, let's just take that as a simple baseline. So when I try to log in, as a member, when I try to log into the third-party application, there could be a very nice link or a button that says, hey, for us to actually show you visually how you're doing with your allergies or whatnot, can we access your information from your payer, right? And when I click on the button to say, yeah, go ahead and access my information, the first thing this third-party client does is, okay, first of all, I want to make sure that you are who you claim you are, right? So what it will do is the third-party client application will redirect me to what we call a authorization server. Okay, and the purpose of this authorization server is to make sure that is to authenticate me, to say, okay, I see that a third-party application is trying to access your information, but I don't know you who you are. So can you authenticate yourself? So at this step, that member is authenticating with the authorization server. And if you're wondering, who has this authorization server? It's basically the provider of the protected resource in many cases. So for example, if you think of this protected resource as your FHIR API server, think of the authorization server as your identity server, where you might already have one in your organizations, because if you have a member portal, and if these members are actually logging into the portal, member portal, behind the scenes, you're authenticating them, right? So it's the same step. The authorization server is asking, who are you? Can you authenticate yourself? And once I provide my username and password, and obviously nowadays the authentication has advanced at least by a couple of steps, where they might actually send you a code, like a mutual factor authentication. Once that member authenticates himself, the next step is, now the authorization server will say, okay, now that I know who you are, Robbie, I see that this third-party application that you are trying to use is requesting your information. Do you authorize? So do you authorize this third-party application to access the information that they are asking about you. Okay, now this is where we have to pay very close attention. This boils down to what we call consent management in real time. It's literally a little screen, a dialog box will appear, pop up on the screen to say, Ravi, this third-party client application is trying to access your name, your email address, your allergy intolerance information, your medication information, or maybe to a certain extent your pharmacy claim information. They may provide that list of things that this third-party application is trying to access on your behalf. And at this stage, at this step where the end member, the end user who is the member will be asked to say, do you allow this? And here is a stage where I, as a member, have a complete authority to say, I didn't realize that you guys actually need all this information. So either the members say, I'm not comfortable sharing with you guys. So they can reject it. And if they say, nope, I'm not allowing you, authorizing you to access all this information, then that's the end of the story. Nothing will go further. That's end of the line. But if they say, yeah, I'm okay, I'm comfortable with this third-party application accessing all this information listed on this consent approval screen, then the end member will basically click on the button that is, let's just say, approve, right? So when assuming the user or the member has provided their approval or consent where a third-party application can access their information, that is when the authorization server will then redirect the user, but most importantly, will create what we call a temporary authorization code. And that authorization code will be given all the way back to the third-party application, okay? And once the third-party application gets that authorization code, it's not an indication saying that, yay, I got all the access of Rob who's the member. I got all the information I'm looking forward to. It's more or less a temporary step to say that, okay, seems like Ravi authenticated himself successfully, and Ravi has provided his consent that my application, that this specific application can access Ravi's information. That's just a temporary consent, right? That's what this authorization code denotes. But once the third party application has this authorization code, the next thing is now it's the responsibility of the client. Remember guys, in the previous steps between step 2 and step 3, step 2 where you're authenticating and then you're authorizing the third party client to access your information, and step 4 where the client application is now successfully getting the authorization code. Until this point in time, if you notice, the client application has not authenticated itself. It was mainly focused on the end user who is the member or the patient. At step 5, once the third party application receives that authorization code, here is the step where now it's the responsibility of the third party application also to authenticate itself using its own credentials. Once again, there are 2 levels of authentication happening here. One is the end user slash member slash patient authentication, and then there is the third party client application authentication as well. Okay, so at this stage, the client, it will authenticate itself, and along with its own credentials, application credentials, it will also send the authorization code that it got in the previous step to say, here is the authorization code I got from you, and here are my credentials. Can you take these 2 and in return give me what we call a OAuth access token? The OAuth access token is what is the it's the key to the kingdom, put it that way. Okay, it's key to access, to get into the right door, to access the right set of information. Once the authorization server takes the authorization code, takes the application credentials, look at both and say, yep, I know who this client is. I know who they are. I have already vetted them out. Everything is good to go. And I also see that it's the right client to whom I provided this authorization code. It does a bunch of its own validations and then written the OAuth access code. Once the third-party client has the OAuth access token, in short, you can also call it token, that's when the client can use the token, the client application here can use the token to actually call your FHIR API endpoint. Okay, so now that you have seen the flow at the very high level, in my opinion, I think it is pretty obvious at least to me, that why CMS and ONC and all the other entities have chosen OAuth as a standard security profile to secure your FHIR endpoints. The big reason, guys, is, as you notice here in the flow, the member, right, or the patient at any given point in time is not sharing their credentials with the third-party applications. I mean to say, the credentials that they are already using to access their member portal or patient portal, they're not sharing them with the third-party applications. So their credentials are still secured. They are with those members, and they only work with the information provider. In this case, whether it's a payer or provider, right? And that nice thing, that's specific to the member. And again, when it comes to the approval, the consent management, it's always the member who is sitting in the driver's seat saying, you can only hate third-party application, you can only access my information if I approve it. Okay. So the resource owner, the member here, has a complete control on who they can allow and they do not want to allow to access their information. So it's a good authority in the hands of the members or patients, right? And then when in the previous step, as you notice here in step 5 and step 6, the client is using its own application credentials to authenticate itself and get a access token. And the nice thing about it is the client doesn't have to share their credentials with the end user as either, right? They both are two different entities. They can keep their own credentials. They can keep their own secrets, but still kind of work together. So OAuth 2.0, if I have to simplify the entire flow or the entire protocol in one, maybe in 3 keywords, I can summarize it as a delegated access rights. Essentially, the member or the patient is basically telling a third-party application, hey, I authorize you to access my information on my behalf and do what you have to do. But again, that doesn't mean that I need to give all my secrets to you. I'm delegating the access rights to my information to you in a confined way, so you can access that information. Okay, a nice and neat separation of concern, a clear separation of concern between the entities here. Okay. Now, you might be wondering, NFF OAuth, where does Openid Openid comes into picture here. Openid, of course, let me go to the next slide. So once the client has the OAuth access token, they can call FHIR APIs, which is all good. But then what is this Openid? What is the big deal about this? Now, always keep in mind that Openid Connect can complement. It's not again, Openid is all about authentication and OAuth is all about authorization. So when you think about for a second, say for example, your client, third-party client application, even though you have successfully authenticated with the authorization server or the identity server, which is all good, they might need a little information about you. A simple example is, okay, Robbie, you registered with our third-party application, great. Maybe just for verification purpose, they want to see when you log in, they want to make sure that, well, when you registered with us, you said your first name is Robbie, your last name is Shinta, and perhaps your middle name is so and so. But then, as part of accessing our application and we trying to access the members' information, as part of your login, I see that that's not what you have registered with your payer or provider. Maybe, I mean, it's not necessary, but they can, what OpenID does is, as part of the member authentication, which was a very first step, it is possible for the third-party application to say, okay, can you just provide me more information about how did Ravi authenticate with you? And also, can you give me some basic information about Ravi, like first name, middle name, last name, etc. Right? So if you need, if the third-party application needs more information about that end user who's trying to access that information, especially from the provider, that's when they can request. Along with the access token, they can also make a request, say, can you also give me OpenID so that I know a little bit more information about Ravi, right? So OpenID, again, it's not absolutely necessary that a third-party application has to have OpenID token all the times. It depends on case-by-case basis, which is why I'm not going to emphasize too much on OpenID Connect and what it does. But let's just say OAuth, once again, OAuth access token is all about that access right, a delegated access right that will be used by a third-party application to call your APIs. And OpenID is all about who is the end user member who is associated with the token, and what additional information can you provide to your third-party applications in addition to the access token. Okay, so again, guys, OAuth and OpenID, they can go as deep as you want. They can go as wide as you want. Very widely adapted, very widely known, and over the course of years, I'm really happy to say that these protocols are very extensible, in a sense that, as you notice here, since this authentication and authorization are completely different from each other, you can use any authentication mechanism as you want. The authorization token doesn't care about it, right? So very, well thought out protocols, well thought out flows. The key thing is, remember to here, is a good separation of concern among all these entities here. So I think at very high level, we did a pretty good job looking at what is OAuth 2.0, what is a flow, one of the flows desired by the Smart App Launch Framework to access FHIR APIs in a secured manner, right? What I would like to do in the next two slides is, I would like to, these are the two key slides that I would like to spend a little bit more time on. Just because the framework says that we have to adapt OAuth to secure your APIs, it doesn't mean that just by applying those protocols on top of your APIs will make everything secured and there are no risk associated. The OAuth implementation can be as simple as it can be, or it can get as complicated as you want it to be. And the reason why I mean by that is, in many Hello World demos and scenarios, I see people, oh, look at this. I'm sending my application credentials and I got an OAuth access token. I'm calling my APIs. It cannot be as simple as that, because what this slide really, what I would like to convey on this slide is, depending for each actor that we saw, there are some known risk associated with each entity. Say, for example, if you are the information provider, say you are the one providing those FHIR APIs for the third-party applications to access. In many cases, what I notice is the mindset of this API providers is, oh, I secured my APIs using OAuth. I got all the checks in place. I honestly don't care about what are some of the security measures the third-party applications are going to take. I'm not responsible for how they build their applications. Are they secured or not secured? You can say that, but I'm afraid it just can't be that simple. The reason is, if your third-party application or client is not secured enough, what if, I mean, just ask yourself the question, what if there is a hacker or a hacker community who hacks into this client application? Okay, good thing is your members' credentials are not compromised. Fine. But guess what? Maybe what they can do is they can steal the OAuth access tokens now that they have hacked into the application. They can use those tokens to access, to call the APIs and get information about the members. That itself, I mean, what if you're returning sensitive data as part of your API responses? You know, it could be PCI, PCI, it could be member information, like, you know, that falls under HIPAA. We need to be very careful in what we've written, and also be careful about who's this client and are they secured enough, because to a certain extent, if the client application gets exposed or if it gets compromised, your member information or patient information could also be compromised. So keep in mind when you onboard these third-party FHIR applications, which I'll talk in the next slide, do vet them out. Understand what are these applications? What are they trying to do with the data? And ask them some basic questions like, are you guys protected against the well-known attacks like cross-site request forgery or cross-site scripting attacks? And what measures are you taking place to make sure that even if someone hacks into your application, they're not stealing the tokens and trying to mimic your application, right? And when it comes to authorization server, which is your identity server, right, where the member or patient is authenticating and granting access, needless to say, I mean, those are API calls as well, you know, and they need to be very secure as well, because if this server is compromised in your infrastructure, God bless, your members' credentials are compromised, and hackers can take those member credentials and they can try to mimic the members, which is actually, to me, a worst case scenario, right? So there are, at each entity, there are known associated security risk. And again, in the next slide, I will show there is a link that is also provided in the Smart App Launch Framework, which is uh, OAuth 2.0 security threat model and measures that you need to take to minimize the risk. I highly recommend, if there are anybody here on this call from security teams, you might probably know this, but if you're not, we'll share the slides. There is a link provided. I'll share that link as well. Do take it, put it in the hands of your security teams. If you are doing this interoperability right, especially from a security standpoint, the one team who should be feeling the heat is the security team. Okay. So I don't want to talk about each and every attack. I just wanted to highlight some of the very well-known attacks or vulnerabilities that each actor is associated, and what you can do. What are some of the countermeasures you can take to minimize or completely block those attacks? Again, I don't want to go through each and every point here in the best interest of time, but I would just say, I just want to highlight on the client actor just for a couple of minutes. The authorization server, the protected resource, uh, just based on my experience and what I have seen out there, your protected resource is not the FHIR API server. In many cases, it will be your API gateway or API security solution that is actually taking the burden of securing your FHIR APIs. So it's just not one system or one entity, it's a combination of entities. You know, when I say a protected resource here, this could be a combination of a web application firewall, a API gateway, which is securing all your incoming traffic, and to a certain extent, I've seen customers also adding more advanced security using artificial intelligence and machine learning. And it is also your FHIR API server. So it's a combination of systems. It's just not one monolithic system, okay? But what I would like to do is just for a few minutes, focus more on the client. What do I mean by security agreement? First of all, when it comes to clients, as a API provider, as a provider of those FHIR APIs, you really need to understand your client and what is the type of the client. In the context of OAuth, you can broadly categorize your clients into two buckets, what we call public and confidential. A simple difference is public, say for example, some of these new member portals or patient portals, from what I gathered working with various healthcare customers, is, oh, we are building this member portal or patient portals using single page applications using React.js or AngularJS. What they mean by that single page application is that application is actually running inside the browser itself. And as you know, if there is code that's running inside your browser, obviously, if I'm a smart member, a smart technical cookie, I can just open the developer tools on Chrome browser, and I can actually see, aha, this application is using so-and-so client ID and secret, and I can actually take those and I can do all kinds of attacks, right? So public clients, basically, they don't have the ability to safely secure their application credentials. So when these public clients have to get a OAuth access token and call your APIs, there are variations, there are certain steps that you need to enable, and they need to respect that. In other words, you need to enable what we call cryptographic extensions on the top of OAuth. Confidential is pretty straightforward. You know, it's like web applications running on a server. They can safely secure their credentials and no issues there, right? So do understand, really pay attention to your client applications, what type they belong. Are they a public client type or are they confidential client? Do understand, and depending on which bucket they fall into, do provide them a checklist to say, hey, since you're a public client, here is a checklist. Here is what we are securing our APIs using OAuth, and you need to meet this checklist, period. No compromise there. Okay. So with that said, again, we'll share the slides, and here is a great resource to know more about all the various threat models and security considerations you need to keep in mind to secure your APIs using OAuth 2.0. Okay. Now I have 3 more minutes to conclude at least the demo, and the last 15 minutes we would like to open it for questions. But there are things that goes above and beyond just securing your APIs, especially FHIR APIs using OAuth 2.0 Openid Connect. Then these things are not so technical, but more, I would say, process oriented and methodology oriented. And what I mean by that is, and I do help many healthcare payers with their FHIR API interoperability or securing their FHIR APIs. And when I work with them, and when they are exposing their APIs to a third-party application, in some of those calls, I often come across the statement, yeah, we understand OAuth, but we are not a huge tech-savvy shop, and I don't think we really can meet every point that you have outlined to call your APIs in terms of OAuth. And oftentimes, either it's lack of education, or either, as they say, they are not a huge tech-savvy shop. So they know what they know, they don't know what they don't know. So I would advise, if you are the provider of this FHIR APIs, do try to step into an advisory role. And what I mean by that is, if your third-party application, if that person or that company organization is saying that they don't understand completely what OAuth is, they don't understand how to consume, get an access token, do educate them, and more in the context of just not a general education. In other words, sending a link on Google, but in your context, if they have to call your APIs, provide them with a complete, thorough guide and instructions on what they need to do to successfully call your APIs. Okay, I can anticipate this. There will be a bit of hand holding, at least when this mandate goes live with many payers and providers next year. And on the top of it, being an advisor, do understand application behavior of your third-party clients. What the reason is, I mean, I don't want to make a big statement about this, but most of you might already know the Cambridge Analytica story, right? With the Facebook, there was a reason that they were in front of a Senate. What happened in that case was, well, the Cambridge Analytica was using the right set of credentials, and everything was good, and they were calling Facebook APIs and getting the information, but they were using that information for something else. Okay, which is why they got into the news in the first place. But the thing is, we need to understand who is this third-party application, what is the service they're actually providing to my patients or members, and if so, how is it expected to work? So for example, why would a member wake up at 2:30 a.m. every single morning in New York and try to get this information? There is something fishy about this. We are not expecting that to happen, right? So the reason why you need to understand the behavior is when these third-party applications consume your APIs, you need to pay attention to the behavior of these applications. How are these applications consuming your APIs? What does that usage trend look like? Are you seeing any abnormal behavior, abnormal trend? And if you do see that, take some proactive steps of asking. 9 out of 10 times, guys, all my members, when they use your application, it happens between 8 a.m. and 5 p.m. EST. And I just noticed that in the last 1 week, I'm seeing very abnormal, like I'm seeing a lot of activity in the middle of the night. Are you sure your application is that expected? Are you seeing the same activity, or what's going on, right? Auditing, it all really all boils down to application behavior analysis and auditing, okay? The third point here is around, as I said, some of your clients, third-party clients, even though they might not be all technical savvy, and even if they're technical savvy, they might need a good platform or a playground to test your APIs. In some cases, I still see that, hey, here are the Word documents and PDF guides, go read them, and then you can use your own choice of tools to test these APIs. If possible, do enable what we call API developer portal and make it self-sufficient in a way that if there is a third-party application developer who would like to consume your APIs, they don't have to bother you, bug you all the time. Just point them to the developer portal where it can clearly outline, here are our APIs, here is what the sample request and responses look like, and here is how the security flow work. And if you would like to go ahead and play with it, register yourself, identify yourself, and play with our APIs before you actually include them in your third-party applications, right? And with all of this, the fourth point is the most important thing. Even though I mentioned earlier that if you guys are doing this interoperability and securing APIs right, the security team should be feeling the heat, but it's just not the security team. It should be, it's a combination of developer, security, and ops, operations team. Because just because your APIs are secured using OAuth doesn't mean they are not vulnerable. Because say, for example, what if your client application is compromised? They could call your APIs at unprecedented rate and they could flood your systems and they could essentially create what I call a resource starvation problem of your servers or of your resources that are supporting your FAR APIs. So it's again, when a developer or a development team is building and trying to expose a FAR API, have them sit with your security team, sit with your ops team, and completely and thoroughly talk through who are the expected clients who would be consuming this API, what is the expected usage behavior, what is the volume that is expected, do we have enough, do we have all the security fences in place, do we have enough capacity to support that volume, and most importantly, even while building this FAR APIs, there, they have to consider security by design. Where what I mean by that is, I don't want to take too much time on this call, but I can, if you have any questions, I can provide more information. It's called API security by design. Okay, do take a look at that. And most importantly, if you have money and if you can make that additional investments, there are some third-party applications like Ping Intelligence and a few others where they do look at your API behavior, usage behavior from your third-party applications. They apply advanced machine learning algorithms to kind of proactively detect that something is not right, something is fishy, and what exactly is going on. So again, all of this are just, all these measures and considerations, they go above and beyond the technical protocol. All right, guys, with that said, sorry, I ran a little bit, 5 minutes over. I will stop now and I will open the meeting for questions.
Ravi, thank you very much for a very informative presentation. We have a couple of questions in the chat room right now. I'll read the first one off to you. A question on OpenID ID token. When we say OpenID is used for authentication, what does it really mean? User member will get an authenticated using by any means like LDAP, etc., which may be external to this flow. So is the purpose of OpenID token only for the client application to verify some user info, but not actually authenticate the user? Does this mean an app should build this logic to consume ID token and then verify some user info?
That is a great question. The answer, it's a multi-part question, so I'll try to address it step by step. First
Sure.
of all, when we talk about, let me just go back a few slides here, especially authentication. When the resource owner is trying to authenticate with the authorization server, yes, behind the scenes, the authorization server can be integrated with the LDAP server. There are LDAP server or any identity server you might have in place. In some cases, it could be a database which is holding your end user's username and password. Okay. So once that user is authenticated, the OpenID, the authorization server typically can do is it creates, just like OAuth access token, it can create what we call OpenID token. And the information that goes into this OpenID token can be whatever you want it to be, but keep in mind, it's very specific to the resource owner or the end user who authenticated. So for example, it can be a high level demographic information about first name, last name, given name, maybe email address, right? But beyond that, there are other things, very cryptic elements, like what was the time of the sign in? And by what means user authenticated with you? Is it through a browser or is it through some sort of a mutual factor authentication that requires a smartphone, right? And if so, how long is the user session is going to be valid, right? So there are other cryptic information that can be included within the OpenID token, and that OpenID token at this stage can be given back to the client application. Now, in the client application can look into the OpenID token. It can maybe, if all it needs is, I just need end users basic demographic information, I'm fine with it, fine. But there are some third-party applications which wants to make sure that the user actually authenticated just a few minutes ago and their user session is still valid. They have not logged out with the authorization server, because they want to make sure when they are accessing your application, they better be signed in and their session is active for all the time that they're doing whatever they're doing with the third-party application. And in some cases, I have seen that the client application will actually, along with the OAuth access token, will also pass the OpenID token to the protected resource, because the protected resource, if you have an API that is highly secured, and it needs to know that, yes, let's just say that API cannot be invoked by a client application unless and until the user actually authenticated maybe 5 minutes ago or 10 minutes ago. They want to make sure that this API is only called when user actively authenticated and using a third-party application. It's not where the user logged in 2 days ago, but then the client application is holding on to that token and not getting any further approvals from end user and just accessing their information. So there is this concept called tofu, not the tofu that we find in the grocery store. It's called trust on first use. Again, depending on the API, the data that you are sharing, is that a kind of data where you want a member or patient to approve that access every time? Or is it just the one-time thing? They do it the very first time and that's it. In all the subsequent attempts, they don't need to go through the authorization grant flow or anything. As long as they can log in, boom, all the consent management, consent approvals will be skipped, where the client application will get the token and directly call the APIs. So the purpose of OpenID is it can be used by your client applications, but at the same time, for certain specific scenarios, depending on your API and what you are returning within that API as a response, the OpenID token also has information that your protected resource can leverage.
Thanks, Ravi. Next question, we have one more. We have about 5 minutes left in the session. How do you reconcile this level of hand-holding with the CMS rule that you have to support all third-party apps that patients want to use? That's a big ask, and they may not all be amenable to listening.
That is a very, 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 very good question, and I'm afraid there is no silver bullet answer, if I may say that. I mean, put it this way. I often encourage my healthcare customers to adopt what I call a day in the life of a customer approach, which is, well, you might not have hundreds of client applications, maybe there are just 3, 4, but if you can work in a sense that if you can identify who these client applications are, and more importantly, if you can identify the client type, as I was mentioning earlier here in this slide, is it a public client or a confidential client? What you can do is, it can be a simple HTML page that you can host on your system or give access to your clients, where they can say, guys, if your client application is a public client, here is all the steps you need to, here is how we would authenticate you, authorize you, and here is how you can invoke our APIs. If you're a confidential client, here is the flow that we encourage you to implement. Even if you can just get that nailed out and publish it to your client applications, you'll be in a good shape. What I mean by hand-holding is, initially there could be some, but again, the more education that you can provide through something like a developer portal where you can show people how they can consume your APIs, the less hand-holding you can do. I'm afraid not many healthcare customers do today. They are still using Word documents and PDFs and emails, and apparently finding themselves in the middle of the storm. You can avoid that. Encourage API developer portal, make that portal almost like a new site, where people can go read what you have to offer, read how they can access your services, look at a sample flow, and even mimic that flow, even without writing a single line of code on their end. When you get to that point, no more hand-holding is required.
Excellent. Thank you so much for that answer. It looks like let's see, I'm going to try to get this last one in from Mike Kennedy. Mike asks, couldn't you do the same thing by re-verifying the auto token? Mike, if you're still on, if you can add a little bit more context.
No, I just meant the auth token. What's interesting is I heard the explanation about using the auth token as further verification, and I thought, that the end server could also ask that the authorization token you could revalidate against the Oauth server, and if it was revoked, you could revoke it there. I'm sorry, it's a minute point. I was just trying to figure out if the authentication token adds value on top of the authorization token, which you can also re-verify against the Oauth server.
It certainly does. It certainly does. And again, it really depends on the type of the client and what they're trying to do. The more security that your client application is adapting, they can use both auth token and authorization token.
And I agree with what you're saying. You never become 100% secure. You can only get more secure. But I mean, I just thought your explanation was interesting, because I just wanted people to realize you can actually re-verify an authorization token at any time, and it can be revoked at any time.
Oh yeah, absolutely. It's a standard token management.
Yeah.
Again, as at any point in time, while your member or patient is using this third-party application, and on the receiving side, if you're seeing a abnormal login behavior, or if you're seeing an abnormal API usage, because in this case, as I mentioned, the tokens are just not bound to the client application. The token is also bound to the end user, right? So on the API usage analysis, if you're observing those trends, you should be able to see that something is just not right about it. And if you have even 1% of suspicion that something is not right, to your point, you can completely revoke that token.
Thank you very much, Ravi, for such a fantastic presentation as part of our national conference pre-conference session. We're going to move on to the next session that we have on the schedule for today. It's my pleasure to introduce Robert Tennant with MGMA. He is also a WEDI board member. Rob, take it away.
Thank you, Michael. And the first thing I want to do is add my thanks to Ravi and Axway for really an excellent presentation. I think some of the issues you dealt with are going to be facing this industry going forward. We wanted to transition over to the next session, which is going to be the coordination of benefits data insights for health plans presented by Rebecca Beatty from CAQH. But before we do that, I wanted just to remind folks of our schedule going forward. You'll see here on the 15th, we're going to have eSolutions, part of Waystar, discussing healthcare innovation catalysts. And then at 1:30, we're going to have a demo day for attachments. We'll have one session presented by Edifex, a next one by Tibco, and that will lead us into what I believe will be an outstanding program on the 16th, on Friday, which will be a very interesting discussion of sort of the current environment for attachments, but more importantly, looking forward to see how the industry can leverage electronic attachments to improve workflow and decrease costs. And again, you'll be sent the links to all the registrants on Wednesday. Then next week, we'll be looking at a very full and robust conference. The first day will be focused on a WEDI work group and sub-work group meetings. And then we move into the conference day 1, day 2, and day 3. And if you've seen the agenda, you know that this is a program you cannot miss. We've got some great speakers, not least of all Don Rucker, who is the national coordinator for HIT, and we've got Dr. Green, who is now head of the CMS Office of Burden Reduction. So very germane to the work you're going to be doing in your organizations. So we're looking forward to that those sessions next week.
Real quick, Rob, for those looking on screen, of course, October 22nd is not a 15-minute day. That goes on. It's going to be a full day on the 22nd. That's a slight typo on my side.
Thank you, Michael. I think part of the value of the WEDI programs is your ability to ask questions and get involved. So I strongly encourage you to leverage the chat feature. Ask your question. We'll have some time at the end of this program to have Rebecca address those. So please use the chat and ask your questions. And with that, again, I am absolutely delighted to introduce Rebecca. CAQH has been a strong and long-term supporter of WEDI, so we thank you very much and looking forward to your presentation. Thank you, Rebecca.
Okay, thank you so much. So I will go ahead and share my screen. Okay, and so I just want to go over kind of an agenda of what we will be going over in this presentation today. So first,
real quick, Rebecca, real quick, the screen did not share.
Oh, it did not share. Okay, let me try that again. Can you all see the screen now?
No. Let me see. If you're running into a problem, let me do this. I will pull up your slides that you sent me the other day.
Okay, perfect.
Give me a second. pulling them up now.
Okay.
All right.
All right, great. So if we could just skip to slide 3.
Okay.
Okay, so, or sorry, just go back one slide.
Oh, sorry about that. Okay.
No problem. Sure. So just to go over a little bit of an agenda for the session today, I wanted to give an introduction to CAQH for any of you who may not be familiar with our organization. And then I'm going to speak a little bit about some of the industry challenges that we see with coordination of benefits and present some best practices for addressing some of those challenges. I'll be talking a little bit about Cob Smart, which is the solution that CAQH has related to coordination of benefits. And then I'll be sharing some data trends and insights that we've pulled out of the data that we have in the Cob Smart database. So we can move to the next slide. So if you aren't familiar with CAQH, we are a nonprofit alliance of health plans. And our goal is really to try to streamline the business of healthcare by finding inefficiencies and promoting standardization so that things don't have to be done different ways multiple times. So what you see here on the screen are our board members. And so we have several health plans and also associations who sit on our board and who give us direction on which problems in healthcare they want CAQH to tackle, and also work really collaboratively with us to determine how to solve those problems. So on the next slide, so we have 3 sort of arms at CAQH, and likely you're all familiar with CAQH Core, which stands for the Committee on Operating Rules for Information Exchange. And so Core, in association with a lot of health plans, writes these operating rules and also has a certification program that plans can join to demonstrate that they are adhering to these rules. You may also be familiar with the Caqh Index, and that's a publication that's put out by the Caqh Explorations team. And the index is published every year, and it really benchmarks progress in the industry on moving from manual transactions to electronic transactions. So certainly something that I think if you're not familiar with the index would be very interesting to this group. And then our third arm is our solutions arm, which is what I'm representing today. And we create what we call industry utilities, which essentially are solutions that bring a lot of health plans together to try to create standardization and automation and reduce administrative burden around certain issues in the industry. So you may be familiar with ProView, which is our solution for provider credentialing. And like many of our solutions, ProView really leverages sort of a one-to-many approach. So we bring health plans together to agree on certain standards that need to be met for provider credentialing. And then that way the provider only has to go through that process once and can credential with multiple health plans at the same time. And so we have some other solutions that leverage a similar relationship. So ProView for Groups is our product that allows credentialing for groups. We have a product that works on standardizing primary source verification. We have a product that is focused on the accuracy of health plan provider directories, a product that monitors sanctions against providers. And then EnrollHub is our product that allows providers to enroll for EFT and ERA with multiple health plans. And then Cob Smart is our coordination of benefits solution, and I'll be speaking quite a bit more about that solution later in the presentation. So if we could move to the next slide. So I just want to mention, Rob mentioned we have worked with WEDI for a very long time, and CAQH is very, very much aligned to the WEDI mission. Our goal really is to promote the use of electronic transactions, automation, and to leverage one-to-many relationships to try to reduce administrative burden in healthcare. So on the next slide, so now I'm going to speak a little bit about some of the challenges that we have seen in the industry related to coordination of benefits and that our member plans bring to us. Next slide, please. So I assume most of you are familiar with the concept of coordination of benefits, but for those of you who aren't, coordination of benefits is the action of when a member has insurance through more than one health plan, plans are allowed to coordinate the benefits between themselves. So they don't all have to pay the full amount for each claim. And there are rules that determine which payer is the primary payer and has primary payment responsibility for that member, and which payer gets to pay secondary. And so we see numerous challenges related to this process, largely because right now there isn't really a good way to share information across payers, because every health plan tends to approach coordination of benefits differently. So there isn't a common language that health plans can use to communicate regarding coordination of benefits, and the data that is shared between health plans that is necessary for coordination of benefits to occur often is not of the best quality, and often is also very outdated. So if data is only coming once a year from a patient survey or being taken from inbound claims data, the data that is achieved through both of those means really is not the level of quality that is necessary for effective coordination of benefits. So on the next slide, so the biggest challenge that we see is really that because of the issues I discussed earlier, coordination of benefits tends to be extremely reactive. So health plans get claims, they pay them, and then afterward, they try to figure out whether they really needed to pay that entire claim or not. And so there are a lot of problems that are associated with approaching coordination of benefits this way. So on the next slide, we see that this has a lot of negative impact to plans, to providers, and to patients. So on the plan side, plans who are mailing out survey letters to their members have told us that it's very expensive to do that, and that they often get very low response rates to those surveys. They've also told us that when they pay claims incorrectly or they overpay, it's very expensive to try to recover that money, especially if they're relying on external vendors to do that. And there's a huge administrative burden on the health plans to try to coordinate these benefits using this poor quality data, using external sources, and trying to communicate when there's no common language. We also see a pretty significant impact to patients and providers. The biggest being, of course, when claims are not paid correctly or on time, that really has a negative impact on both of those parties. Providers also express a lot of frustration with a lot of phone calls that are coming to their offices that tend to be very disruptive to their workflow. And patients tend to be very confused and frustrated by those survey letters. They really don't understand coordination of benefits. They don't understand what is trying to be achieved through those letters. And so they really feel like health plans should be able to just figure this out between themselves and not involve patients at all. And we estimate that the cost of inefficient COB is around $800 million. And a significant impact or significant portion of this is borne by providers. So we think this is an area where there's a lot of room for improvement. So on the next slide, I do want to speak a little bit about the impact of coordination of benefits specifically on Medicaid plans, because I think there's a very unique challenge and opportunity for Medicaid plans. So one of the biggest differences between a Medicaid beneficiary and a regular health plan member is that Medicaid beneficiaries often have multiple breaks in coverage in a single year or potentially even in a single month. So if you're only getting data on that beneficiary once a year, it's very, very likely that that data is going to be outdated, and there's really no way that they can capture all of those changes in coverage that are occurring in that year. But we also know that there is really a good opportunity for Medicaid payers because they are always the payer of last resort. And so if Medicaid beneficiary has coverage through somebody else, most likely the Medicaid payer will not be responsible for the bulk of those claims. And we see that this is happening in about 13.4% of situations where there is overlapping coverage for a Medicaid beneficiary. Next slide. So now I'm going to give some best practice recommendations for meeting these industry challenges. The next slide. So first, as we mentioned, right now, a lot of organizations take a very reactive approach to coordination of benefits, and our challenge is to really try to shift that to a much more proactive approach. If coordination of benefits information can be loaded into the system before claims come in, and therefore those claims can be paid correctly, then we can really eliminate all of those impacts that we discussed earlier. But in order to do this, what you really need is a good source of very high quality data. I think one of the reasons a lot of people aren't able to do this is because they simply do not have that data, especially when they need it. And so finding a source of trustworthy data is really important for effective coordination of benefits. An additional recommendation that we have is to prioritize your high dollar claims. We know that health plans really have limited resources, and so we recommend focusing on those that are going to give you the greatest potential for savings. So to give you an example, one of the health plans that we work with, they've essentially set a threshold, and anything that falls below that threshold, they consider to be a low dollar claim, and they outsource those claims. And then anything that falls above that threshold, they work those in-house. And they've shared with us that they had really significant results from taking that approach. They were able to save quite a bit of money and achieve a lot of savings in a very short period of time. We also, of course, want to encourage everybody to leverage automation. As much as you can auto-load data into your system, then you can really reprioritize FTE time for things that do need manual intervention. We also recommend separating recoveries from identification, especially if you're outsourcing these functions. This is certainly an area where we think if you separate those, you will be getting better data. And then finally, we highly recommend that you work to take the member out of the middle of this process. When you are relying on members for COB data, we can almost guarantee that you are not getting the best quality data. What we understand is that members, they may not even be aware that they have other coverage. Those who do may be unwilling to share that other coverage information with the health plan because they do not believe that if the other health plan knows about it, that the other health plan will pay their claim correctly because they don't understand how the coordination of benefits process works. And so to the extent that you can coordinate benefits without involving the member at all, not only will you be getting better data, but you also will be reducing member abrasion. Next slide. So I also want to give you just a few key considerations to take into account when you're choosing that data source. One is, of course, where is that data coming from? Is it coming from other health plans? Is it coming from your members? Is it coming from claims data? Where is it coming from? Because that has implications for the quality of the data. How often is it updated? As we mentioned, if you have members who are going in and out of coverage multiple times a year and you're only getting that data updated once a year, there's no way that you're capturing all those changes. When do you receive the data? How much does it cost? What is the impact on your staff and your members to receiving that data? Next slide. So now I'm going to speak a little bit about the Cob Smart Solution. And the reason that we developed this solution was because our member plans came to us and expressed that they really needed a better source of data to conduct coordination of benefits. And they were really looking for a way to better communicate with other health plans so that this process would be better. So go ahead to the next slide. So what we have developed is something that we are hoping will help health plans take a more prospective approach to coordination of benefits. So giving health plans access to enrollee-specific information that is frequently updated, identifying overlapping coverage, and then determining primacy all before those claims are paid. So on the next slide, so this is how the process works. So every week, health plans submit their enrollment data to us. So we get a file that includes all of that health plan's membership every week. And then we compare that membership list to the health plan list that we're getting from all the other health plans. And that way we can uncover overlapping coverage where we see that a member has coverage from two different sources. And then we apply the NIAC rules to make primacy determinations. And so all of this is very automated and then is sent back to the health plans every week so that they get a file that has all of the overlapping coverage information. And then they can use that data either to recover claims that have already been paid, or ideally they're loading that into their claim system. And so that information is there whenever claims come in. And that way they can take a more proactive approach. One thing that I think will be interesting to everybody on the call today is something we've instituted very recently. And this is something that we've done to really try to ensure that the data that we are sending is of the highest quality. So we already think that getting data directly from other health plans is the best source of the data, but we know that there's some latency in the data. We know that depending on where the health plan is pulling the information from, there can be some variation in quality. So to do an additional double check on the data, we have started every time we uncover an overlap through this process, initiating an X12-270 inquiry to the other health plan's source of truth. So both plans in that overlap receive this X12-270 inquiry, and that way we can ensure that this coverage is still active, and that we can also double check the term date and make sure that we have the correct term date so we know when that coverage is going to be termed. That is then sent back to us in an X12-271 response. And then all of this information is sent to the health plan in that weekly file. So this way the health plans can see which overlaps have been validated through this service. Those that have been verified, they can auto load, and those they don't have to do any manual intervention on. Those where we send back information indicating that something needs to be cleaned up, that's something that we can do automatically to update their file, or they can clean that information up themselves. So through this process, our goal has really been to find a way to automate the ability to double check all this data and send only the highest quality data, so it's very actionable for the health plans. So next slide. So I want to just give a little bit more detail about the validation process. So as I mentioned, every week we compile all the overlaps and then we generate a 270 inquiry to each plan in the overlap. And we do send those real time. They're not sent in a batch format. And we are using Experian Health as our solution host. So that is the organization that sends and receives the X12 inquiries for us. And below, I've just given a sample X12 data stream. So you can see what this transaction looks like and the information that we are sending. So if we could move to the next slide. We also have a portal that we have created to make this data easier to use. And the portal is a service where health plans can easily do one-off lookups of a member to see what overlaps that member may have. We also, because we are trying to promote more automation, we have an override feature now where if somebody needs to correct something for a member record, instead of having to go back to their weekly file and make the correction there, they can make the correction in the portal, and then the portal will actually auto-correct their file. So we, once again, trying to work on the quality of the data and make it as easy as possible to keep all of that data updated. Another thing that we've released very recently that we've seen a lot of success with is what we're calling the workflow tool. And the workflow tool allows someone who's in the portal looking at an overlap who sees that there is something, some action that needs to be taken regarding that member and needs to reach out to the other health plan in that overlap. So previously, this would have been a very manual process. This would have involved probably picking up the phone, trying to get through the customer service system at the other health plan, trying to find the correct person at the other health plan to talk to about this member. But the workflow tool enables this person now to just simply set an inquiry, send it directly to the appropriate person at the other health plan. And so both of those people's workflow is no longer disrupted. They can work those inquiries when they're in the portal, they can work them all at the same time. And it really decreases the amount of time that needs to be spent on the phone or manual intervention that needs to happen, which is really the goal of the solution and the goal of CAQH. So if we can move to the next slide. So here's just an example process that a lot of our health plans take to use the Cob Smart data. So every week they take the CAQH weekly file in. They have written internal business rules to determine which of those data elements are going to be auto-loaded and which will require manual investigation. So our goal, of course, is to have them auto-load as much as possible, and that was one of the reasons that we started doing the validation service, so that health plans felt very comfortable taking the data, knowing that it had just been validated through those X12 inquiries last week, can now take the data and automatically set it up into their system. It automatically sets a flag on that member record saying that there is COB for this member. And then when a claim comes in, that can be processed as secondary. And also routes a certain amount for manual investigation. So for those that we were not able to validate, they may need to do some additional manual investigation of that data before they're comfortable setting that COB flag and treating it the same way as the other data. Another thing that we see health plans do is give portal access to people across the organization. So it does not just need to be limited to the COB team. So it can be given to, for example, COB operations, claims operations, prepay and high dollar audit operations, and recovery operations, so that people across the organization have access to this information before they make decisions. So next slide. And so since I will be going into some insights and data trends that we've pulled out of the COB database, I wanted to just give you an idea of the type of information that's included in the database. So currently we have more than 60% of all US covered lives included in COB Smart. And so you can see the heat map of where that's most concentrated. And we do have all large national payers are included in the solution. We have very good coverage from many of our Blue Cross Blue Shield plans, and some smaller regional payers have also joined us. And then we do have recently just added our first state Medicaid plan. So our goal is really to get as many people into this database as possible, sharing this information, because the benefit is for everybody that the more people who join, the more information is available, and the more people who can participate, for example, in the workflow and communicate to each other directly that way. So the goal of this, as I mentioned, is really to decrease the amount of administrative burden associated with coordination of benefits. And the more people who participate, the more impact we can have on that burden. So the next slide. So this is kind of the breakdown of types of membership that we have in the system currently. So right now we're at about 64% commercial group. We have about 18% Medicaid MCO, so it's a really large portion, about 10% Medicare Advantage, 4.5% commercial individual, and a small amount of Medicare supplement plans. So next slide. So now I wanted to share some data trends and insights that we were able to pull out of this database. I think this will hopefully be useful information for you all to potentially benchmark your own COB metrics against, because we do have such a large database of information. So we have some polling questions in here, and I'm hoping this session can be somewhat interactive. So on the next slide. So what we have here is the change that we're seeing in COB rate by line of business over time in our database. So would be interested to hear if you all are experiencing something similar. But what you can see, the light blue line that we have here is just medical COB rate overall. So that's the summary of all these together. But what I think is interesting is that for most of the lines of business that we have, the COB rate last year started out around between 8 and 9% for all of these lines of business. And then some of them have gone up quite a bit. So commercial group, we saw a pretty significant increase in COB rate. And we also saw an increase in Medicaid MCO. But the one area we've certainly seen a decrease is in commercial individual coverage. And we think this may have something to do with COVID, that perhaps people are giving up commercial individual coverage to save money during this time or losing it. And so that's an area we've actually seen fairly significant decrease. The one area that tends to have a lower COB rate overall is Medicare Advantage. So you can see last year it was around 5%, and now this time it's only about 4.5%. So not a huge drop, but lower overall, and we have seen a slight decrease there. So we would like to launch a poll now. So we'd like to just hear, are these COB rates similar to what you are seeing, or are they higher or lower? So far I'm seeing a couple similar, one lower. So we'll give people just a few more seconds to vote. All right, so it looks like for most people, these are similar COB rates to what you're seeing, which is certainly what we would like to hear. And sounds like one person maybe seeing lower COB rates than what we're seeing. So just interesting, I think, to have this as a benchmark for your own organization. So if you can move to the next slide. So one other thing that I thought might be interesting to share is the reasons when we are able to determine primacy. So when we send overlaps to the health plans each week, of course, our goal is always to determine primacy and let each plan know who is primary. But there are some scenarios where we cannot determine primacy, and I'll speak to that a little bit more on the next slide. But the most common reasons when we are able to determine primacy, one of the biggest is when we're looking at a subscriber-dependent relationship. And of course, here the NIAC rules are very cut and dry. And we most often are applying the birthday rule in this scenario. So that's about 40% of the overlaps that we're sending over are determined for that reason. Another very significant portion is because when we have a Medicaid payer and we have another payer, the Medicaid is, of course, always going to be secondary, and we see that about 35% of the time. And so this goes back to what I was speaking about earlier for the unique opportunity for Medicaid plans, that, of course, whenever we find an overlap for them, they are generally always secondary. And then the third most common reason where we find an overlap and we are able to determine primacy is by length of coverage. So, of course, the plan that has had, or the member's coverage that has been longer, generally is the primary payer. So on the next slide. So this is the most common reasons when we cannot determine primacy. So the first is, and most common, is when we find coverage, we find more than 2 forms of coverage for a member. So we certainly have rules built in on how to deal with 2 forms of coverage, but anything beyond that, we do not currently have logic built into the system. And so certainly when we see data like this, we know that many times an individual may have 3 forms of coverage, but this also tends to be a red flag to us that we should just double check the quality of the data and ensure that, in fact, all 3 of these types of coverage are still available. And so, excuse me. So when we have more than 2 plans, one of the things that we have developed recently is we have what we call the member override, or sorry, the group migration feature. And when we see, so this is something that we've added that uses the logic that's built into the system, that when we see that there is a large group that suddenly has coverage overlapping coverage, that didn't have coverage before. What that indicates to us frequently is that that may be a group that migrated to a new form of coverage. And so if you, so that signals to us that we need to let the health plan know, hey, you have a large group here that you may need to simply term their old coverage because you're getting a ton of false positives, indicating that there's an overlap here when in fact this was just a large group that needed to be migrated. So that's something that we have recently built into the system that allows, we give a flag to the health plan letting them know that this group probably needs to be migrated. If they confirm to us that that group needs to be migrated, then we can easily auto apply all the correct term dates for that group so that it removes the rest of the false positives and cleans up the database. Another area where we are not able to determine primacy is if we have more than one Medicaid plan. So in that scenario, it's really needs to be coordinated between the plans. And then the third reason why we are not able to determine primacy is if the health plan has not indicated which business model needs to be applied to that member. So of course, if we don't know the business model, we cannot determine primacy in that scenario. And so all of these things, once again, are just tend to be red flags to us where we think about whether there are ways that we could potentially clean up the data and ensure that all of these overlaps really are correct and that this information is actionable for the health plan. So next slide. So one other thing that I think is very interesting that we've seen is in reviewing the coverage that we have in the database, we found that more than a third of the overlaps that we find are actually coverage that is coming from a different state from where the member resides. And so I think a lot of people would assume that if you have a member who has overlapping coverage, that it's going to be in the same state in which they are contracted. But we find that that's really not true in a pretty significant number of cases. So what this tells us is that it's very important to have a national perspective when you are looking at coordination of benefits, because if you are only getting data from in-state, very likely you're missing out on a pretty significant portion of overlaps that you could be coordinating on. And then next slide. So the last thing I wanted to share is some information that we've been tracking around the impact of COVID-19. And so what we have here, this has been very interesting to us, is the total medical membership that we have in the database by week. So on the bottom row, you have the total membership that we had in 2018. And as you can see, it fluctuated quite a bit. 2019 was a little bit smoother. And then in 2020, so starting in March, of course, this is when we started to see COVID-19 hitting. I think what a lot of us were expecting, given the amount of job loss and other very unfortunate things that have happened because of COVID-19, is we were expecting a pretty precipitous decline in membership in the database. And that is really not what we have observed. There was a slight decline, there have been some slight up and downs, but a lot of these are actually due more to data cleanup efforts that have occurred, because as you can see, this is really kind of rebounded. And so I think what this indicates to us is that at least so far, people who may be losing their employment perhaps were not in jobs that were offering them medical benefits. So it's, at least so far, what we've seen is this is really holding pretty steady. We will, of course, continue to monitor this as time goes by, and it's possible that as people start, perhaps, furloughs become permanent, other things happen, it's possible we may start to see a more significant decrease. But as of yet, we really haven't seen as big of a decrease as we would have anticipated, given how much unemployment we're seeing. So on the next slide, one thing that may be driving this slightly, so now we have our membership broken down by line of business here. So the top, so this is total medical membership that we were just looking at. This is our commercial group coverage. And as you can see, there has actually been a slight decrease in the number of people who have commercial group coverage. And then there has been a corresponding slight increase in the number of people who have coverage through Medicaid or Medicare. And so I think what this is suggesting is that possibly some of those people who are losing their commercial group coverage are then becoming eligible for Medicaid or Medicare. And so that is perhaps offsetting some of the decrease in membership that we would have expected to see. So now I would like to just launch a couple of polling questions. So would be interested to see, have you seen any impacts of COVID-19 on your membership? Has there been no impact, a slight decline, a slight increase, or some other change, which feel free to enter in the chat box. Okay, so far I'm seeing no impact. Give folks a few more seconds to weigh in. Okay, so similar to us, it looks like those of you on the call are experiencing the same thing, that there really hasn't been much of an impact of COVID-19 on your membership. Okay, and then the next question I'd like to ask the audience. We can move to the next slide. Is do you anticipate any long-term impact of COVID-19 on coordination of benefits? And if you could just enter your thoughts into the chat box, I'd like to hear what your thoughts are. I think we anticipate, of course, if there continues to be job loss, there is potential that we will see a decline in membership, and therefore we will see a decline in the number of overlaps. But would be interested to hear if any of you all have thoughts on any other impacts that you anticipate from COVID-19. So if you all have any thoughts, if you could just, at the chat box at the bottom, if you could enter your thoughts there. Yes, and that's a great point that Rob just made about seeing a change in coverage due to the ACA being challenged in the court. So that's certainly another thing that's on the horizon, in addition to COVID, that could really have an impact on membership. Okay, well, thanks everybody. That concludes my presentation, so I'm happy to take questions at this point.
Great. It's Rob Tennant again. First of all, I wanted to thank Rebecca for an excellent presentation. In particular, very interesting data points you presented. I think we'll be watching the industry closely over the next, I wish only for the next few weeks, but I suspect the next several months as the pandemic continues to impact healthcare. But let me turn to some questions. Rebecca, do you have a message for payers considering the data validation process to be able to auto-load data to their system, but perhaps are not sure if they should move forward with it?
Absolutely, yeah. So one of the things that all of our users who have been using the data validation service have done some user acceptance testing after getting their first file with all of the data validated. And so a lot of them have told us that they, of course, wanted to verify that the validation service was working. And so they did take all of the validated overlaps and make phone calls on those overlaps to make sure that what the validation service was finding was correct. And they were very pleased to see that they were getting 99 to 100% hit rate, that those X12 inquiries were very, very good at finding the correct information. And so they, after conducting that UAT, were able to feel comfortable with moving forward with auto-loading that data. And so a lot of them have expressed that their ability to auto-load data has gone up pretty significantly since they've been using that service.
Excellent. And what is the value of executing a 270, 271 transaction?
Sure. So, of course, those of you who are familiar with them know that those are standard industry transactions. So one of the benefits is that pretty much all health plans are already set up to send and receive those. So it's leveraging something that the industry is already using. And the benefit is that, the data that we're getting is really dependent to some degree on what the health plan is sending us. I think all the health plans really try to send us the best data that they can, but depending on how the health plan is set up and the size of the health plan, and whether they're potentially pulling data from a warehouse or from some other area, is that the information that is sent to us may or may not be 100% correct. And so the benefit of using those X12 inquiries is that that really verifies that data in a very clear and clean way, so that everybody's comfortable that the data that they're getting is really correct. And as I mentioned, they can move forward with auto loading and they can use that data without doing any further investigation of the data.
Very helpful. Let's dig a little deeper into that, because of course many of the folks on the program know the 270, 271 from the EDI transaction flowing from the provider to the payer and back. What's the difference between that 270, 271 and the one that CAQH is sending?
Sure. So really the main difference is just that instead of this going from provider to payer, this is going from us directly to the payer and back. So we are just sending an inquiry that is pulling just coverage and term date. And so that's being sent just to both of the payers in that overlap to ensure that that overlap is still valid.
Gotcha. We had a great question from Janice. Couldn't you just do 3 sets of pairs to determine first, second, and third, or whatever permutation is needed? Clearly, all the criteria you mentioned seems conducive to that type of.
3 sets of pairs.
Yeah.
Got it. Yeah, no, I think that's a great suggestion. Right now, we're just not set up to do that with our logic, but we do have on our roadmap to add some additional things to our analysis and to our logic. So certainly that's something that we could potentially leverage in the future.
Great. And I remind folks, if you do have a question, please enter it in the chat. And maybe a final one until we get something in the chat. What would you consider to be the single most important element that will deliver a real value for a health plan?
Sure. So, I mean, I think the thing that's really the most valuable is getting data directly from another health plan. I think a lot of other data sources really rely on things that may not be updated very frequently. But if you're getting data that's directly from another health plan, especially after it's been validated using those X12 inquiries, that really is an overlap that you can use to coordinate benefits.
Excellent. I don't see any other questions. So with that, I just want to thank Rebecca once again. Thanks to CAQH and Axway for their continued support of WEDI. And with that, I will turn it back to Michael.
Thanks, Rob. And this concludes day 2 this week of our pre-conference sessions. Just wanted to show everyone real quick the rest of the schedule for this week. Of course, we have Healthcare Innovation Catalyst, how HHS can turn 2020's challenges into opportunities, presented by eSolutions. And then our attachments demo day. Links will be sent Wednesday. A unified approach for attachments, presented by Edifex, and accelerating the fire with 275, presented by TIBCO. And then finally, Friday, our WEDI National Conference Attachments Workshop, taking place from 11 a.m. to 3:30 p.m. Some fantastic speakers there. So that information will once again be sent Wednesday. We welcome everyone to participate and be a part of this expanded educational experience that WEDI's putting together as we approach our national conference. Everyone have a great day and a great week, and we'll see you soon.